Hi, everyone. Welcome to Quality. This is Arjun Venkatesh, your host, lead of the Emergency Quality Network, and welcoming you to Exploring Quality in Emergency Care with us. Today, we've got our next episode in our series that's part of the EQUAL Stroke Initiative. Today's topic is going to be the dizzy patient, and we've got two amazing guests with us. Dr. Zackerson and I, who lead the Stroke Initiative, are joined by Dr. Chris Carpenter, who's Vice Chair of Implementation and Innovation at the Mayo Clinic. He's an emergency physician, and he was the lead author on the SAEM GRACE-3 guideline on the approach to dizzy patients. We're also joined by Dr. Bruce Lowe, who was with us on Quality in the past, and he's Chief of Emergency Medicine at Sentara Norfolk General Hospital, and he's lead author of the ACEP Clinical Policy that was also recently released on taking care of dizzy patients in the ED. We're going to try to cover a lot of ground today. It's a really challenging diagnosis, thinking about posterior circulation strokes in ED patients that are dizzy. There's a couple of these guidelines out there that we're going to try to distill down for you. And we're also going to go through a couple cases. And so I'm going to say welcome to these guys and kick us off with, I think, a topic that has come up and made it, unfortunately, a little confusing in the clinical environment, which is that these two guidelines came out around the same time. And I think, unfortunately, like many things, there was a lot of write-ups and the throwaways and other things that focused on the differences between the two. But my guess is that there was a lot more that was similar or where there was consensus between the two. And so I was hoping you guys could just briefly tell us about each of the guidelines, what some of the key recommendations are. And for our clinicians out there who are listening, what's the latest when it comes to evidence-based care for that dizzy patient in the ED? Chris, you want to kick us off?
Yeah, Arjun, thank you. The differences are mostly due to the approach used to derive each document. SAEM's GRACE approach uses grade methodology that hundreds of organizations deriving clinical practice guidelines have adopted and used over the last decade. GRADE is intended to be thorough and transparent, including the selection of content experts and patients with lived experience for the writing team who formulate focused questions, independent of whether significant quantities of research exist for that question. GRACE incorporates both direct evidence and indirect evidence, commissions external systematic reviews that get published, and then they also generate this evidence to decision framework that clearly communicates the problem, the strength of evidence for benefits and harms, the balance of benefits versus harms, feasibility, acceptability, cost, values, equity, and implementation considerations. So how did that translate to GRACE-3? GRACE-3 focused only on dizziness as opposed to the ACEP Clinical Policy, which had one question. One of the four questions was focused on dizziness. And because we had content experts and the entire document was focused on dizziness, we split it up into dizziness subtypes, which frankly, I had never heard of before we wrote this document. There's acute vestibular syndrome, which is acute onset and continuous dizziness for greater than 24 hours. Spontaneous episodic vestibular syndrome, one or more discrete episodes of untriggered spontaneous dizziness or vertigo, and triggered or positional episodic vestibular syndrome with one or more discrete and very brief episodes of triggered dizziness. The ACEP Clinical Policy, on the other hand, lumped them all together as dizziness. And it's very important because those timing and triggers determine the diagnostic approach and the therapeutic approach.
Thanks, Chris. Bruce, tell us a little bit about the ACEP approach and how that clinical policy came about.
Yeah, no, thank you for that. So Chris is right. There's different organizations have different approaches in terms of the methodological approach. And the way ACEP presents it is we take specific discrete clinical questions and we try to address them into a PICO type format, as opposed to the SAEM or other organizations where they do kind of a more of a general disease-based approach. And so what you have for the ACEP policies are very discrete questions. And we had 4 questions related to our recent stroke policy, and one of them was focusing on dizziness. And I'll have to say that, for similarities, for both the SAEM and ACEP, we have separate methodologists that review the evidence. And what was interesting in both cases was that the same articles were reviewed by the different groups of methodologists. And based on the methodology, how we approach it, and SAEM uses grade, ACEP uses a kind of our own homegrown type of approach, we came up with different levels of evidence, even though we're looking at the same body of evidence.
So these guidelines documents are very thorough. It's like you guys said, there's a ton of evidence. I can't remember how many citations there were in each of them, but for most of our listeners out there, obviously they can't make it through and read all those papers. And so they'll turn to these guidelines and often look at the recommendations and try to figure out, well, okay, what am I going to do on my shift tomorrow night? If you look back at those 2 documents and think about your own practice, were there 1 or 2 recommendations that you thought of as, this wasn't something I was doing before I sort of had the chance to be part of this guideline group, see all this evidence, get it put into a recommendation format that would change your practice on your next shift?
For me, there's three things, Arjun. One was the failure of the traditional approach that I was taught to ask the patient, describe what you mean by dizziness. That's a complete failure. It does not distinguish subtypes of dizziness. You need to rely on timing triggers, which is more history and physical exam. Number two was the complete lack of effectiveness of any of the therapies that we were taught to use, like meclizine, like benzodiazepines. Maybe for some subtypes of dizziness, those might be effective sometimes, but generally they're not effective. That was news to me. And then the third shocking thing that we're probably going to talk about more in a minute is CT scans for acute dizziness patients. Doesn't matter what subtype you're looking at, the likelihood ratio positive and negative are 1 for all of them, meaning it doesn't change your post-test probability of posterior circulation stroke. That was news to me.
Yeah, and for myself, I would say similarly in that our approach to the evaluation of dizziness, a lot of things that we were taught really were not very effective in terms of distinguishing central versus peripheral. And then what is available out there, at least in the evidence base in the literature, is fairly limited. The other thing for me is when we talk about HINTS specifically, is that, and I remember trying to do HINTS over a decade ago in corporate practice and kind of fumbling through it. There's definitely a learning curve that goes along with it. And some of the evidence kind of indirectly suggests that, if you don't have training or if you're not sure what you're doing, you can use it inappropriately and kind of go down a wrong pathway. So tools such as HINTS or any tools at all really require some degree of education and training to go along with it.
I think the HINTS exam is one of the places where we've seen some of the differences sort of be discussed, but I would have said from my perspective, as I looked at the documents, the differences weren't as profound as I actually was worried that they would be. In the ACEP policy, really the focus there was on the studies and that who was involved in the studies and who performed the HINTS exam in the studies that were being used for the evidence. Whereas the SAEM document sort of pushed the idea that we need to have training if we're going to use it. Are there other sort of places of overlap or distinction that you think are worth noting? And related to that, how do you think we should be thinking about HINTS? More than you already sort of mentioned, Bruce.
Yeah, I think you nailed the kind of the key differences in terms of the SAEM document and the ACEP document. I think the SAEM document's a little bit more forward-looking in terms of trying to raise the bar or kind of push those boundaries, whereas the ACEP document really is, what does the current evidence say? And I think to your point, looking at those who are specifically trained or highly skilled in the particular techniques, such as HINTS, it seems to make a lot of sense. But the question is, how applicable is that to the general population if you don't have that specific training? And I think that's a question that really is a little bit more out there and a little bit kind of not 100% clear. And which is why, the ACEP document really kind of gave it kind of a low-level recommendation and recognizing there is value in techniques such as HINTS in terms of differentiating peripheral versus central. But as of right now, at least, and looking at all comers and that kind of external validation, it didn't seem overwhelming, at least based on the methodology, how we review the evidence in the articles.
I think it's like a lot of different practices, right? Sometimes we probably oversimplify something like HINTS as being, it's just like a physical exam maneuver. So if you can check extraocular movements, okay, maybe you can probably do a HINTS. And then under those circumstances, there's not the education and the training that you would sort of want there to be to do it well, versus we would never say, for example, evaluate a new point of care ultrasound technique, right? Without education and training. We'd say, well, if you want to do an ED echo and ED echo is effective, you would sort of presuppose everybody knows how to do an ED echo. And so I think that's where we have this tendency sometimes with physical exam, particularly, to just kind of just toss it in a bucket and be like, oh, it's all the same. It's all something you can learn in second year med school.
Yeah, from a GRACE-3 perspective, talking about the HINTS exam, I think there are 3 challenges that we recognize that really I hadn't thought about before GRACE-3. One is applying the HINTS exam to the correct patient. I just thought dizziness, apply HINTS. That's not what you do. Number 2 is performing HINTS appropriately, which requires training and monitoring training. So mentoring and doing the skill. And that's something most of us didn't receive during our training. And number 3 is interpreting the HINTS appropriately. So you have to apply it to the right patient. You have to know how to apply it, and then you have to know how to interpret it. And those are pretty distinct skill sets. And the thing that infuriates me a little bit hearing people talk about HINTS is that there's this perception that we can't possibly learn it. Emergency medicine is incapable of learning the skill that frankly many neurologists know how to do and many physiotherapists know how to do. And I don't understand that mindset. If we can put in chest tubes and intubate patients and put in central lines and learn ultrasound, why can't we learn the HINTS exam?
Arjun, I think you have a great analogy comparing it against point of care ultrasound. There's really two aspects when you talk about a new technique and what you do with it, right? There's the acquisition of data, right? So for ultrasound, it's actually performing the physical maneuvers to acquire the images, and then the interpretation of data. And the problem becomes, I think, is if the first part, the acquisition of data, is inadequate, or you don't do a good job, or you're not really sure what you're doing, the interpretation becomes moot because you have bad data that you're trying to interpret and trying to incorporate into your clinical practice. And so the same thing with HINTS, right? And I think it's not so much the interpretation of data. I think we all can sit in the lectures or read the blogs or studies or whatever and really understand what it takes to interpret. But it's really the acquisition, I think, that really scares a lot of people. And Arjun, to your point is, and to Chris' point also, part of it is also just a skill set. It's just a technical skill that we can do to learn. But how do you learn that skill set, especially when other people around you may not be comfortable? So you can't turn to your partner or a mentor, or like when you're a resident, like you're attending the supervision to kind of get the skill set. And if you look at ultrasound, point of care ultrasound, the evolution, I mean, it's been part of the model of emergency medicine for 20 years, so 2 decades. Yet still, what is the level of uptake, right? We're still trying to get the community folks to incorporate, bedside ultrasound into their daily practice. And we've seen some uptake, but probably not nearly as much as you expected for a couple decades. And I think it's the same kind of challenge of how do you get that incorporation, that skill set, that comfort level. Again, we talk about the studies and external validation, but it's also about the local validation, right? The individual skill set and comfort level, and how do they do it when they talk about acquiring and performing the HINTS examination.
And GRACE-3 valued that education so much that we made that our #1 recommendation, is the education is required. And we created a bedside app for smartphones to assist folks that want to learn the HINTS challenge at the bedside. But the app is not the same as training. We believe that there's innovative workshops necessary at ACEP, at AAEM, at SAEM to train the trainers, and then somehow virtually monitor knowledge uptake and application of this knowledge after the training. So that's why we made it our #1 recommendation.
I love that. The app is not the training. That may apply to a variety of things in emergency care education.
I'm going to move us toward imaging here, if I may. I think, there's really no shortage of attention, whether in our emergency medicine world or even the sort of Monday morning quarterbacking that comes from outside of emergency medicine. And we also know in our clinical experience that posterior circulation strokes are hard to diagnose. And so in that context, and, also as we're accepting that tissue-based diagnosis is sort of where we're going as opposed to clinical diagnosis of TIA, we're thinking about diagnosis of TIA and stroke differently with respect to imaging. We also, at the same time, know that imaging resources vary a lot between emergency departments. We surveyed our equal participating EDs and know that half of them, a little over half, don't have 24/7 access to MRI. A couple of them don't even have access to MRI. So as we're thinking about the diagnosis of stroke, the diagnosis of posterior circulation stroke, the sort of variation in resources between emergency departments, I'd love for you guys to reflect a little bit on how we make sense of that and how we sort of should think about that together.
Yeah, I think that's a great question. And just like you were saying, the diagnosis for stroke has really moved to a tissue-based as opposed to a clinical base. And, when we look at what resource we have available to us for most emergency departments, at least in the US, CT, right? The donut of truth, right? And that's kind of the one that we have easily accessible. Yet we know, at least in the acute setting for stroke, it's really not a great test, at least for ischemic stroke or making the diagnosis. Yes, it can rule out a lot of other things. And if you see, an acute stroke on CT, that's great. But oftentimes, especially in the hyperacute period, you're not going to see that on CT. So then what are your other options? CT angiography is kind of becoming more and more commonplace, especially with stroke programs and stroke alerts as part of the stroke workup. One of the interesting challenges is, are we doing too many CT angios? And that's probably another discussion worthwhile at another point. But in relationship to dizziness by itself, if you look at the studies, it's actually also a pretty low yield test, right? Studies will say maybe between 1% to 2% of CT-CTAs will be positive for something or some sort of acute finding. So that really leaves us with MRI. And so I think more and more EDs now have access to MRI, but not every emergency department. It is still a limited resource, even for those that do have it. There are some EDs that actually have ED MRI, right? MRI dedicated to their emergency departments. That's still far and few between, but it's, again, a limited resource. What's interesting is if you look for dizziness in the literature and how good is MRI, and specifically isolated dizziness, it turns out that even MRI, right, the best test we have is fairly limited. There's a study from 2007. It looked at how good was MRI in the hyperacute scenario within the first 3 hours of symptom onset. And it was interesting because half of the strokes that were missed by MRI in this scenario were either small strokes and posterior circulation. If you think about it, those are the same strokes that cause isolated dizziness. So even MRI, when it comes to isolated dizziness, you're not having other neural findings, right, has limitations, at least in the hyperacute period.
That's great. In fact, Bruce, that's a great kickoff to some of the cases we want to go through today. For our listeners, I'll tell you that we told these guys who are national experts in the evidence around the approach to the dizzy patient that we would do some cases, but we didn't prep them on all the cases. And so we'll get the real answers today on how to approach these patients when you see them in the ED. And I'll kick us off with the first case that is very similar to that question about imaging. A lot of community emergency departments may not have 24/7 MRI, but what we find in the Emergency Quality Network is that they do have access to next morning MRI. They also have, a lot of them will have some capabilities to do ED observation, whether that be in the ED or in a small obs unit next to the ED. And so I think a clinical scenario that comes up really often is the patient with isolated dizziness, who you initially see in the emergency department, may even be a stroke code, but is not somebody who necessarily has to be immediately transferred to a comprehensive stroke center, is not going to get thrombolytic therapy or mechanical thrombectomy or some sort of intervention, and in whom you might have had either a non-con CT or CTA, whichever it might be initially done, that's normal, and they're dizzy, and you're concerned potentially about a posterior circulation stroke. What's the approach to that patient in that scenario? Should we keep them overnight for an MRI? Is that a priority? And should that just be what we do as care? Or is it discharge and get the MRI later? Or should we really be transferring all those patients to get the MRI that night to whatever our referral center is?
Yeah, I think that's a great question. And it really depends, I think, what resources you have available to you at your institution, what kind of environment you're working at. And also, based on your history and physical examination, right, what's your pretest probability this person's having a concern for a posterior circulation stroke? I think in an ideal setting, what would happen is if there is concern, and whether that's based on the history or based on your physical exam findings, but it's not 100% obvious, right? There's no other focal neurological deficits that really leans you to definitive, but there's definitely concern. I do think keeping that patient for advanced imaging, MRI, is appropriate. So for instance, let's say you are proficient in doing, say, the HINTS exam, and it's HINTS concerning, definitely I would keep that person. If you're not comfortable, or maybe you tried to do the HINTS and it was non-diagnostic, you really couldn't make heads or tails, like, was it positive or negative concerning, but there is still a concern in your differential about the patient, and you have the ability to keep the person and get the MRI the next day, I think that is the appropriate way to do it, similar to kind of a TIA stroke workup in a patient.
Great. Now let's take that same emergency department and that same patient, but we're going to add some years to their age. Patient now has diabetes. They have some risk factors. They've never had dizziness like this before. They have all these things that make us think, gosh, this person just looks like somebody who's going to have a stroke. Is that going to change at all how we're approaching them?
GRACE-3 recommends a stroke protocol MRI for patients with acute vestibular syndrome and equivocal or central evidence of HINTS results. That's a strong recommendation with high certainty of evidence. That's something we had a lot of debate on, whether that's really high certainty of evidence. Then for patients with spontaneous episodic vestibular syndrome and concern for TIA, we have a conditional recommendation with modern certainty of evidence for MRI. And then CT is never recommended in the setting of acute dizziness, regardless of subtype. MRI is not recommended for triggered episodic vestibular syndrome with typical posterior canal BPPV response to Dix-Hallpike maneuver. So we rely a lot on the history and physical exam. We've got systematic reviews, by the way, our own systematic reviews that we published for the diagnostic accuracy of CT and MRI to back up some of these statements and the certainty of evidence. GRACE does not address the question of transfer for MRI versus delayed MRI, but I can tell you the tone of the discussions in the room when we're discussing GRACE-3 recommendations was that if a physician who's trained in HINTS or the staining algorithm is concerned for stroke, then imaging and therapy should occur as a time-dependent emergency. Translation, transfer that patient. Do not keep them overnight, because this either is you're concerned about stroke or you're not. And if you're not sure, you got to have protocols in place to transfer them. Don't wait all night.
So that leads into the next twist on this case, which is it's easy, I think, or not easy, but we've done it a lot. We usually have our stroke systems built around the MCA syndromes, right? And so when a patient comes in and they've got something that's lateralizing on their exam and you're concerned for stroke, it's really easy to get the trains in motion, particularly if that's going to be transferred to another center. It gets harder as the clinical syndrome becomes a little bit more uncertain and the exam becomes a little more uncertain. And so one of the questions I've always had around these cases is it's easy in the retrospectoscope to decide, well, oh, that patient should have been transferred because they needed treatment. And it's easy to say that when the stroke syndrome is more obvious. How do we approach that in these dizzy patients? You're that same ED that, you know, has the ability to have an inpatient capacity and admit a stroke patient, but doesn't have treatment capacity. And so how do you know when you've got this patient who's come in with dizziness? Is there any way to differentiate who's at higher and lower probability of needing treatment to help you in that transfer decision? Or do we have to really think about a model where, because there's not something that helps us make that differentiation in that initial ED visit, we're going to either have to transfer them all or something like that?
Yeah, I think you just nailed on the head. That is the challenge, right? And our tools that we have available to us, especially if you're in a critical access facility where you don't have all the bells and whistles and specialists and subspecialists at your fingertips, it becomes very, very challenging about what to do. Definitely, I think if there is concern for central process, right? These people, I think we all agree, can't go home. Ultimately, the question that you're posing is, and the twist, I think, is, you know, do we transfer them? And let's say your facility can manage a general stroke patient, but can't do thrombectomy. It's very hard to transfer somebody without direct evidence that there's an LVO or right something that they're going to go after and intervene, especially in this day and age where hospitals, especially tertiary quaternary referral centers, are busting at the seams, right? And they can't even get in the regular patients, much less, you know, these patients that may see quote unquote softer. You know, my other hat that I wear as medical director of the transfer center for our health system, I mean, we battle this issue all the time. And I can't tell you how many angry phone calls I get on a regular basis, right? People frustrated, they can't get their patients in a timely fashion to the appropriate facility. So I think that is the challenging question. I do think that when it comes to treatment, though, at least acute treatments, while it's not 100% clear, I do think that there's a trend toward that if it's isolated dizziness by itself, chances are nobody's going to do some sort of acute therapeutic treatment, right? Either thrombolysis or thrombectomy if there's an LVO. Clearly, if there's deterioration of symptoms or worsening of symptoms and within the treatment window, either for thrombectomy or thrombolysis, obviously it becomes a different story. But then it becomes a question of, you know, do you do CT angio in every one of these patients or not? And what's interesting is there is some talk, at least nationally, from the imaging radiology side about, you know, are we overdoing it with CT angios, especially with patients that don't have other focal neurological deficits. And I think that's something that's going to continue to evolve. And really, we don't have a great clear-cut answer at this point, at least based on the evidence. But I think to your point, it really is something that we need to kind of ideally prospectively have a plan so that at 3 a.m. on a Friday night, we know what for our frontline physicians that are working in the emergency department, that they know what to do if they have this type of scenario and kind of have pre-planned. And that will really depend upon the relationships you have with your outside transferring facility for a critical access hospital, or even understanding kind of what the limitations and capabilities are at your own facility.
Arjun, I do think the ACEP clinical policy does give some direction to this question, particularly with LVOs. The question number one gives a litany of decision aids that can help identify patients at high risk for LVO, including many of those studies had posterior circulation strokes included, and give strength of recommendation for which of those patients should be transferred. So I would look to the ACEP clinical policy document there.
All right. Last twist on our case for you guys is same sort of older patient. We're still concerned that they have dizziness and, you know, posterior circulation stroke is on the differential. Same emergency department again with same level of resources. but we're actually thinking there may be a better explanation for these symptoms, and I'm not so concerned about a posterior circulation stroke. I just can't rule it out. So in that case, making the argument to, transfer and get really aggressive feels like a stretch. And I feel like I don't know if, that's really the right use of resources at this point. How do I approach that person?
Well, from the GRACE-3 perspective, we do encourage uniform HINTS training of physicians so they can be more confident in their ability to distinguish central from peripheral causes of vertigo. And then if there is concern enough for stroke that you cannot convince yourself the findings are equivocal or indicate a central cause, that patient should be transferred immediately, like we said before. If for some reason the physicians don't have the access to that training and aren't comfortable with the online learning that's available, there are many websites that can show you these maneuvers and how to interpret them. I would encourage them to think ahead of time about who else they could call to help perform those maneuvers. Is there a neurologist that can come in and perform the maneuvers? Is there a physical therapist that can do this? Many physical therapists are very adept at these procedures. So that would be the GRACE-3 approach.
And I'll add that we'll also learn through this process that for vestibular rehab, if your hospital has that, so these are physical therapists, to Chris's point, these people oftentimes are actually trained or can learn how to do the HINTS examination because they see this cohort quite frequently. So they get a lot of practice kind of in their daily practice on these maneuvers.
It's interesting because I think, we probably historically, we have a lot of quality directors, medical directors that are listeners and, leaders within the eQual network of their local QI projects. And when we think of stroke care, the natural partners, the multidisciplinary committees that we form, the stroke task force or stroke QI team at each place is usually a mix of emergency physicians, neurologists. If you're at certain centers, there's a neurosurgeon in there or interventional radiologist if you're doing thrombectomy. There's a huge nursing team thinking about this. There's transfer center. But I got to say, until today's conversation, I'm not sure that physical therapy has been commonly part of that group and part of that conversation. But increasingly, it sounds like they may be a really critical partner for many emergency physicians as you're thinking about setting up protocols, pathways for care. Guys, this was awesome. This was a wonderful conversation. One of the things we always do on quality is make sure that our special guests get the final soapbox. And so you're both really smart. You've brought a ton of evidence on many different things, and we covered a lot of ground today. But if I gave each of you the soapbox and there's one thing you want to share with our listeners to make sure that they take away from this whole conversation, the floor is yours. Chris, you want to go?
Sure. I would point the listeners to the entire May 2023 issue of Academic Emergency Medicine, which is entirely focused on dizziness approaches, journey stories about how physicians got to focus on this area, all the systematic reviews on diagnosis and therapy for every one of the questions in GRACE-3, and some interesting statements from our patient population. The patients with lived experience were quite disappointed in the status quo of dizziness management in the ED, based on many of them having been in ED 50 or 100 times for dizziness. And so I think that's a really interesting read for our audience to know about.
Thank you, Chris. We'll make sure to include that issue in our show notes as well.
Yeah, I would say that having given talks a number of times, either nationally or internationally, and talking about dizziness and HINTS, I always ask the question before I start, how many people use HINTS in their daily practice? And it's usually around 20 to 25% of people will raise their hands. And then I'll follow up the question is, of those who raised your hands, how many feel really comfortable with your ability to perform and interpret the HINTS and actually incorporate into your regular practice? And that's where you see the vast majority of hands that kind of go down, and literally you're just left with a couple people who have their hands raised, kept raised up. As we talked about earlier, when it comes to dizziness, especially acute vestibular syndrome, I mean, a lot of what we learned in the past really just isn't great in terms of differentiating central versus vertigo. And especially if you're in a critical access hospital and you have to make the tough decision, are you transferring somebody 2-3 hours away, right, away from their home? And God forbid you can even find a place that's willing to accept your patient, right? Especially if it's not getting some sort of acute therapy. What do you do, right? Understanding, again, limitations of imaging that we just talked about earlier. And I think this is where HINTS, can really come into play, right? So people who want to elevate their game, and so forth. But it's tricky because, again, none of us were taught HINTS when we were training. And how do you actually get comfortable? And I like to go back to the analogy of point of care ultrasound. And I think, to me, the best way to do it is to do it. And so when you get trained in point of care ultrasound, if it wasn't part of your residency training, going to your 1 day, 2 day class, and when you come back to your emergency department, what I always tell people, and I used to teach bedside ultrasound, point of care ultrasound, is do the ultrasound, but don't make any clinical decision. Order the formal test, right? And then compare the results of the formal test with your ultrasound to see how that you did. And eventually you end up building confidence that what you're seeing and doing actually is consistent with, at least your local gold standard. And I would say the same thing to do for the HINTS examination, right? Because the question is, how do we even get started to build that technical expertise, that local technical comfort level of performing the HINTS? Do the HINTS, right? Read online how to do it, take those courses, get the app, and take a look at it. And then incorporate it into your patients. And then don't make any clinical decision the first couple of times, but do what you normally do, right? Admit them in the hospital, see what happens when they get the MRI, right? Does the result of that is concordant or discordant with the results that you got at the bedside? And it's not until you do enough of these that you really start to become comfortable and then you can start incorporating it into your daily practice, as opposed to just jumping in there, doing your daily practice and really trying like, am I comfortable, not comfortable, and then not really being comfortable and then kind of abandoning and not really kind of incorporate into your practice. So look to do that. Just do it. Practice on, if you want to get comfortable looking at nystagmus, especially changing nystagmus, look at your drunk patients. We all see drunk people that kind of hang out in an emergency department, right? That's the perfect population, right, to start practicing your HINTS exam, assuming they're cooperative and let you do it, right? You have really nothing at risk, and you get a sense of, oh yeah, there's something wrong that I'm getting, or hints concerning, right, from the central process, and you can see that in your intoxicated patient. So there are ways to kind of practice and get comfortable, at least to a certain degree, without having to make it a kind of a high stakes in real time, 3 o'clock on a Friday evening.
I love those recommendations. And, as I'm sort of reflecting on what you guys have been saying, this is another place where, as always, the trainees are smarter than us. And I'm thinking about some of our residents who graduated last year and were going to smaller community hospitals with very limited inpatient capacities. One was critical access, one was not critical access. And it was really interesting talking to them because as they were finishing up their 4th year residency, they were particularly interested in learning HINTS, getting adept at ultrasound, because for them, they would tell me, they said, hey, I'm going to go work somewhere where I don't have 24/7 support from radiology for a variety of different things. I got to decide whether I'm going to transfer a patient or not transfer a patient. And so the armamentarium of tools that you need are different in that context. And I think we've, historically said, oh, well, we'll do these things in academic medical centers, but it's actually the flip that is entirely true. Whereas where we need these tools are in people that are actually in decision-making positions in emergency medicine to have huge impact on the flow of patients across our acute care system. Thank you both. This was an awesome discussion. We'll look forward to having you both back again in the future. I think I want our listeners to sort of walk away from this knowing that there is much that we can learn, much that we can do to improve our care for the dizzy patient in the ED. Don't get caught up in sort of this guideline versus that guideline. I think there's a lot that we can learn from both these documents that summarize evidence in different ways and even different pools of evidence in some ways. And so keep tuning into Quality. We're going to have additional episodes in the stroke series focused on diagnosis and supporting your QI projects. And today was just yet another great episode in that series. Thank you all.